I really appreciate the opportunity to talk to you, and thank you, Seattle Science Foundation, for inviting me to talk about something I'm super passionate about. So I live in Olympia, practice at Capital Medical Center, and a partner in an orthopedic group. And my real disclosure for you is that I'm a spine surgeon who met a robot and fell in love. I do have some required disclosures, you can peruse those. But as we talk about robotics in 2017, spine surgery in general, this is like the most exciting job. This is like the best thing to be doing right now. We are at this moment where everything is changing. Our ability to do surgery, our ability to correct problems is just getting better and better and better. And robotics is playing a big role in that now and will continue to do so as we go forward in the future. Navigation. The past 25 years, people like Dr. Johnson creating this great, wonderful work, this body of work showing us that we can reproducibly and safely place screws with fiduciary markers and fluoro, and then later unshielded CAT scans in the OR. And these things can help us do a better job. But just like stagecoaches, even adding cup holders, maybe some rims on them, once we get into robotics, once that automobile comes by, we realize the intrinsic advantages. And there's really no need to go back and develop more stagecoach technology. Robotics allows us to be precise. It increases patient safety. It minimizes radiation in the OR. And it's improving outcomes. And thus, as robotics has taken over manufacturing in the United States and throughout the world, it's doing so in spine surgery. And I think well within our lifetimes, this will be the standard of care. And I'm going to tell you why. It's about safety. The robot guides your hand to placing the screw. Navigation systems are really great. They give you the target, they show you where the crosshairs are supposed to go, but you have to steady that instrument to put in. The robot's going to guide your hand. It's going to be there precisely. You're going to put it in the right spot. You're going to know the exact depth, the angle, the location, the width, and to maximize the pedicle. You're going to know your anatomic pitfalls before you even get in there. It's going to do just as good a job on your bad day as on your good day, or good day and bad day, I guess as those would be. And it's going to do it with minimal amount of radiation. So by definition, 50% of spine surgeons are above average. They all happen to be in this room, and congratulations. This type of technology, just like navigation was mentioned earlier, allows you as an above average surgeon to do stuff that makes you even better. It allows you to explore techniques, and I'll show you an example of some of those as we get into the cases, that you might not have been able to do or not able to do as well without it. But for the 50% of surgeons that are by definition below average, and of course none of them are in this room, but they are out there, they're in the world, this type of technology will allow them to do standard surgery safely. It'll get them up to average, and this rising tide will raise all of our boats. Now the data. Major publications in every single major spine journal. Over 160,000 screws placed and not a single permanent neurologic deficit with the robot. This study by Van Dyke had just under 500, I think it was 492 screws, 98% accuracy. And on the screws that were misses, the ones that weren't exactly where they wanted them, none of them were impinging on a nerve or required any sort of replacement. No revisions. This is a paper by Dr. Johnson and his colleagues, where he noted out some of the advantages of robotics. The fact that it's very, very precise. The fact that it eliminates the human component. If you have a hand tremor, if you're tired, this is your third operation of the day, it's 3 o'clock in the morning, you're doing that fracture. Your hand's not involved in this. minimizes radiation. And they even went on to propose that should robotic spine surgery provide an avenue for MIS surgery, that it would be the standard of care. Radiation. Now that we have these unshielded CAT scans in the OR and are doing multiple spins for the fiduciary markers and such, we're getting more and more radiation exposure to our OR staff, to the nurses we care about, the anesthesiologists, in my case, that we love, and even to ourselves. Paper after paper is showing that this has clinical significance to us as a spinal community. This paper shows that neurosurgeons are dying of an increasing rate of leukemia. Where do we think that's coming from? This study says, well, you know, I'm wearing a lead apron. I should be okay. Well, lead aprons, it turns out, are only good at protecting us from about a third of the radiation. But what's really neat about this paper is it was done in Korea, and the surgeons that they used actually broke down into two groups. There was one group of surgeons doing surgery the traditional way. There's another set of surgeons that were doing MIS robotic surgery. And when they broke down those cohorts, there was a 77% reduction in the amount of radiation the robotic group was using compared to the traditional group. It allows us to do minimally invasive surgery with a degree of precision that really is just unmatched. And it's taking navigation to the next level. This study here by Dr. Carrick was looking at, I think it was 407 cases of minimally invasive spinal surgery that they did, placing almost 2,000 screws, and then they analyzed the data off of those screws. They did miss a few CAT scans here and there, so they didn't end up with the full number. But of the number that they did study, they had 97.7% accuracy. The screw went exactly where they wanted it to go. They had 2% that were within 3 millimeters, which was what they defined of where they had planned, and they had 7 screws that were outside of that, which they did revise, which led them to a 1% revision rate. And then they took their data and they compared their minimal invasive technique with the literature of people doing that technique without robotics, and they came to the conclusion that their published rate, their rates were lower than rates published with the series of percutaneous screw techniques. This study says that in adults with low-grade spondylolisthesis, use of the robot en masse, using everybody, is going to lead to less takebacks and revisions. I've used it myself for some revisions. This was the pseudoarthrosis of the most cephalad level and adjacent segment disease. We were able to program the robot, pick an alternative trajectory, and get a nice outcome there. And those of you who saw the talk last year know this guy. Now, how does it do this? Well, you do use some data from before you head into the operating room. And one of the criticisms is that currently, with the technology we have, you do require a CAT scan of the patient. That's a downside. And I know that at least 2 different companies that make robots are working on getting this to where it's MRI and X-ray that merge. So someday, within our near future, we'll be able to get rid of the CAT scans. But for now, it's CAT scan based. And this can be done low dose, but it's still a CAT scan. And you can plan the depth, the width, the XYZ axis of your screws. You can also look for anatomic pitfalls that may approach you if there's large mammary process or something that might get in your way. And you can make all those notes beforehand. One of the advantages of doing this is it allows you to only pick the screws that you need. If you're going to do a multi-level case, say you need 10 screws, you don't have to wash pan after pan after pan and see your scrub techs lug these things into the room. You can literally wash 10 screws. You know what you're going to use. You then execute it by mounting the frame onto the patient or onto the bed, taking 2 reference views, an AP and a 60-degree oblique, and then the robot will send its little arm to where you're supposed to go. And once it's there, the cannula leads you directly to the place that you wanted to go. The pre-measured drill depth will give you exactly the depth that you wanted. You can put in a K-wire, tap it with whatever brand tap you want to use, put in whatever brand screw you want to use. And this is a cutaway showing exactly how that cannula interfaces with the spine. So I'd like to show you a couple cases that I think are illustrative of how this actually works. This is a typical case for my practice. This is a lady in her mid-50s, had a laminectomy done about 10 years ago for back and leg pain, and had relief for about 3 to 6 months after the surgery. Her pain did come back. She was followed, and they said, well, let's send you to PT, and let's give you some shots, try different oral agents, and ultimately she ended up with pain management and got a spinal cord stimulator, which surprisingly did not address the problem. And so what she has is a iatrogenic spondylolisthesis, recurrent foraminal stenosis, and some scarring around the nerves. Well, what are you going to do? So I thought this would be a good TLIF case. So we planned out the screw trajectories to maximize the pedicles that were there. You can see that we were actually really able to fill these pedicles and the size, get the right length. And I set them in such a way that I knew I'd be able to use asymmetric placement of the screws to reduce the spondy. And we did the surgery. It was 11 seconds of fluoro, under 200 cc's of blood loss, and she went home on post-op day number 2 and has been doing pretty well. This is another case. This is a lady that was in her mid-60s. When she was in 1973, she was involved in a car accident, had a fracture, and was treated with bed rest, and has lived with kyphoscoliosis from her post-traumatic injury since that time. She's a tiny lady, so she walks around and she has to really crank her head up to see the world because she's short to begin with, and then she's got this kyphoscoliosis to deal with. Over time, she developed lumbar degeneration, some retrolisthesis of the vertebra, some ligament hypertrophy, stenosis, and got neurogenic claudication. And by the time she sees me, she's suffering from significant back fatigue. It's very hard for her to stay up and interact with the world. Her legs won't let her walk very far, and she's pretty miserable. She's done all the conservative things, and I thought this would be a reasonable case for a biplanar pedicle subtraction osteotomy. Tiny lady, small pedicles, how am I going to do that? So I used the robot. And I planned the screws to maximize the pedicles, and I actually mapped out a biplanar pedicle subtraction osteotomy. I've got the robot, why not use it? And I could make my angles the way I wanted them. And we were actually able to maximize those pedicles, get our biplanar osteotomy set up, and do the surgery. And I think we neutralized the kyphoscoliosis to a great degree. We opened up her spine, and her head is over her pelvis again, and her world is completely different now that she's no longer looking at the floor. She's pretty happy. We lost 300 cc's of blood. We used less than a minute of fluoro for the whole case, including closing down the pedicle subtraction osteotomy. And she went home on post-op day number 3. And as of 3-month follow-up, she's still maintaining her correction. Of course, we're going to follow her for quite a while. And this is a case that I would like to use to illustrate the minimally invasive techniques. So this lady has some significant collapse of L5-S1, some bone spurs, foraminal stenosis, and she has back and leg pain secondary to these things. She's 55, but she's a triathlete and very active. She has done epidurals, she's done physical therapy, she has the strongest core muscles you'll ever see, and she's done all the oral agents, and so how am I going to address this? Well, I figured she'd be a good candidate for a minimally invasive procedure. She doesn't have a lot of central stenosis, it's all foraminal. And I thought, well, we'll do an ALIF and then some interfacet fusion with perc screws in the back. So we made a plan as to how to do that. Now, the problem with a lot of the prior navigation systems, before you get to this, is that they mark off these fiduciary balls. And so if you change the anterior interspace, you're going to have to rescan them and figure everything back out again. But here, we're actually able to do an ALIF, greatly change the anatomy there, both increasing the interspace and the lordosis. And since the robot reads off of the bone, it doesn't change our position at all. So this is the current robot that I use. And I'd like to think of it as that Model T. It's clearly better than a Stagecoach, but it's not refined. There are more and more robots coming out. This is a newer version. And I would say in the next 4 or 5 years, we won't have Model Ts. We'll have Bentleys and Lexus and all the fancy stuff that comes with this as this technology evolves. So it's an exciting time to be involved in robotics, and I'd love to take your questions.